Dr. Preeti, you have to unmute.
Should we start? But there are just 8 students up till now.
Your decision.
Because Uday and Aditya both have some meetings lined up at 12 with the director, so they will have to leave. So I think we should, if they are late, I can't help it.
Yeah.
Yeah, I think we should start, ma'am.
Okay.
Yeah. So, all of you, good morning. This is a carryover from yesterday. All of you have to manage a lot of children in your wards, but most of you are not pediatricians. So, we have this small introduction to management of children in an adult environment. There are basic tips and some information about a lot of resources available on our intranet. And this will be taken by Dr. Vijay Lakshmi Bhatia from Department of Endocrinology. Over to you, ma'am.
Thank you, Preeti. I sincerely apologize for the technical glitch yesterday. And I hope to finish in about 15 minutes. I'm a pediatric endocrinologist in the endocrinology department here. And we will talk for the next 15 minutes on why children are different from adults, how children are different from adults, and what we should take care of when we care for these children in the SGPGI environment. Usually when I start off with this slide, I have a little interaction with the residents asking what is the difference in the depiction of baby Jesus on the left hand side picture from the right hand side picture. But this online this method doesn't have too much scope for interaction in 15 minutes time. So I would like to myself point out that baby Jesus here is like a man painted in miniature, whereas here he actually looks like a baby. And the difference is that in this picture, the torso is is long compared to the legs. So the upper lower segment ratio is different from that in the adult, which looks more like 1:1. The head is big comparatively, and the face is chubby in comparison to this picture. But these are just external attributes, and more important for us when you all will be caring for children is all the internal attributes of physiology and pathology. So we will take up a few of these. Coming to the oxygen demand, which is exemplified here by the minute ventilation per kg body weight per day, we can see that the minute ventilation is 3 times in an infant, is 3 times that of the older adolescent and adult. This has a bearing on the water needs, which are also double to 2.5 times, and the calorie needs, which are about double that of the older child, adolescent, and adult. Coming to the surface area as compared to as a ratio to the body mass and the surface area as a ratio to the volume are much higher in infants as compared to and infants and in toddlers as compared to the older child and adult. This has implications for temperature control, water loss, and the amount of rehydration fluid that we have to give. But coming to history taking now, the very respected Hutchison, which we all have our first clinical foundations, used to say that with what are called subjective symptoms or history taking in children, you are not in any way troubled because there are none. I think he made it look as if history taking is very brief and a big advantage in pediatrics as compared to an adult. And my husband, who is an internal medicine person, never fails to remind me that आप लोगों को कोई history लेने की ज़रूरत ही नहीं होती है. But at the same time, there are some disadvantages. The parents' version of history may actually reflect denial, and we have to be extremely alert to find out the reality. And this alertness comes from observation. So history taking is often substituted by observation in pediatrics. A very well-known pediatrician in the 1800s in France used to say, previous to speech, God has given to the child a language which philosophers call natural language. It is the language of science. And quoting another very famous person who actually founded the well-known children's hospital in UK, Great Ormond Street Hospital for Children, he used to say, "For though the infant cannot talk, it has yet a language of its own, and this language, it must be your first object to learn. If you have not cultivated your faculties of observation, you cannot learn it, for it is a language of science." So history taking is substituted by observation in pediatrics. Um, the method of learning to understand sick infants and children is to first know about their peculiarities in health. And in the next slide, we talk about one or two peculiarities in health which children have, which adults don't have. Children grow, adults have finished growing. These are growth charts. The boy's growth chart blue on the left and a girl's growth chart pink on the right. There are different kind of Indian growth charts. This is called an Agarwal growth chart. There are Indian Academy of Pediatrics charts now, which are very widely used. Both of these are used in our hospital. And let me show you why a growth chart is important. Because charts help us to place the height of the child against the perspective of national reference. So these are drawn from healthy representative children of India. These are the height centiles, the 50th centile, and here is the 5th and 95th. And here are the weight centiles. There are BMI charts also, because unlike an adult where the normal BMI is from 18 to 23 kg per meter squared, etc., the BMI changes in childhood. So we need to have charts. Um, so this child is on the 5th centile line, seemingly within the normal centiles. But if we place him against the perspective of mid-parental height, supposing his mid-parental height was right on the 90th or 95th, this child would actually look short. And we must be worried and not just say that she is within normal limits for Indian children. So that is the second perspective. And the third one is to detect deceleration. If the pediatrician had been diligently taking a height every year, we will suddenly find, oh dear, these heights are now no longer on the 90th centile, but are coming down to the 50th and now right up till the 5th. So it immediately tells us that something is wrong, maybe a systemic disorder, maybe an endocrine disorder, something is wrong in this recent time. And if we are not alert, we will find, and if we don't step in at this stage itself, after detecting this deceleration on the growth chart, we will find that the child has further grown, even decelerated even more. Another thing which children do, which adults have finished doing, is to have go through puberty. So in the adolescent age group, puberty can start anywhere from 8 years till 13 years. The start, mind you, in a girl can be anywhere from 8 years to 13 years. And in a boy, the start which starts with actually testicular volume enlargement only. The pubic hair comes much later in stage 3. The boys start puberty anywhere between the age of 9 years and 14 years. So if we see a 12-year-old boy and we find that he does not have any pubic hair, no testicular enlargement, no pillar enlargement, we should refrain from automatically thinking that he has delayed puberty, with the knowledge that he has anywhere till 14 years to start puberty. Now coming to blood pressure, extremely important. In all of your specialties, in one way or the other, you will be dealing with blood pressure, mostly to diagnose hypertension, but sometimes for hypotension also. And choosing the correct cuff is extremely important. Seasoned people make a mistake. So please pay the maximum attention to this slide. The bladder width should cover at least 40% of the mid-arm circumference. This is the mid-arm circumference. This is the bladder width. So we should place the bladder width-wise like this and make sure that the bladder width, not the cloth, but the bladder width is covering at least 40%. It can cover more, but it should not cover less than 40% of the mid-arm circumference. And the bladder length, which is this is the bladder length. We place it along the arm like this, and that should cover at least 80% of the length of the arm. Then we have chosen a correct size. And of course, the child should not be crying. It's a big challenge. So pediatricians are very patient people. They tie the cuff and tell mom to feed the child or put the child in a quiet environment, give some toys, and have the patience to take the blood pressure when the child is quiet. Otherwise, it is no use. A BP overestimated by a small cuff is much worse than underestimated by a large cuff. So if we don't get a very exact cuff size, choose one which is little larger rather than little smaller. We can also use the thigh. So if we don't get an exact cuff size for the arm, we can take a little bigger one and try it on the thigh and use the popliteal artery sounds, and this gives an equally good version of the blood pressure. So this is extremely important. And what are the normal blood pressures? Normal blood pressures are different in children, not only in children, but in children of different age groups. And after 2004, now in 2017, the blood pressure normals have been revised and the diagnosis and definition of hypertension has been revised. The original article is in Pediatrics, the journal Pediatrics 2017, Flynn et al. It is from the American Academy of Pediatrics, quoting the American Heart Association. And what do they look like? These are the tables. We can't memorize. So these are present, one can print it out and put it up in your wall. We can see that this is for boys. Similarly, there will be one for girls. So it differs by gender. The normal values of BP differ by age and by height. So if we have a 2-year-old child who is very short, the systolic blood pressure 50th centile is 84, but the 95th centile is 92. So we cannot memorize all this. We have to have the charts in front of us. So these are the BP centiles, 50th, 90th, 95th. Now the recent one does not have 99th. I put it up just to show you an example. The new charts actually have some height in inches and centiles, little confusing. So I've just put this up here for clarity. Now coming to the definition of hypertension, normal BP is defined as less than 90th centile for gender, age, and height. And elevated BP, just like in adults, there is a category called elevated BP. So here also the category of elevated BP is between 90th and 95th centile, or in adolescents, 120 by 80. Then comes stage 1 hypertension, which in adolescents is just like adults, that is 130 by 80 to 139 by 89. And in children, it will be more than 95th centile, but less than this, which is stage 2 hypertension, that is 95th centile plus 12, or equivalent in the adult. So in adolescents, it will be equivalent to the adult, which is more than or equal to 140 by 90. Here is a rough and ready calculation. For hypotension, it is important. There's no other way to do a rough and ready calculation for hypotension definition, which is less than 5th centile. So if we hurriedly, we don't have a chart, this is not written anywhere. It's very important to mug this up. 50 plus age into 2. This is the lower cutoff for blood pressure. So below this will be called hypotension. Coming to some investigations, which may be different in neonates, preterms, term babies, and adults. Serum creatinine, very important. Serum creatinine in a preterm is higher than in a term baby, and then in a term baby, it slowly climbs. So many times I have seen people making a mistake, like calling an infant's creatinine, which is like, this is in millimoles, sorry, but calling an infant's creatinine, which is 0.6 or so milligram per DL, as normal. No, even something more than 0.4, you have to be alert for an infant. So definitely they have different normal creatinine than in older children and adolescents. Then some other important analytes, potassium in the immediate newborn period is a bit higher than in older children and adults. Similarly for calcium, little bit higher than in the older child and adult. Phosphorus, opposite. The lower end of phosphorus in a newborn and infant, which is 4.8, 4.5 to 4.8, is actually at the this lower end is actually the upper end of a normal phosphorus for adults. People often make this mistake. So please be alert for phosphorus also. Thyroid hormone is closer to my department. The thyroid hormone values are a bit higher in newborn and infancy than in the whole of the rest of childhood and adulthood. ECGs, many of you know, ECGs are very different in the infancy and children than in adults. I'm not going to have time to go into the details. Coming to treatment issues, drug doses, we have some resources on the SGPGI intranet. There are two big lists of drug doses, two different ways of searching it out, alphabetical as well as drug wise. And one of them has a lot of the adverse effects written very nicely. So we have retained both kind of reference resources. Mm, the IV fluid infusion volumes as well as type of fluid are different in children. Most people know this very well. Up to 10 kgs with approximately during the whole of infancy, 100 ml per kg body weight. And excepting the first 2-3 days of life when we use only dextrose, after that we use N by 5 saline for the first few months and then N by 2. With older children, we will do 1000. This 100 into 10 comes to 1000, and 1000 plus 50 ml per kg up to 20 kgs, and 1500 plus 20 ml per kg beyond 20 kgs. Beyond 3 to 5 years of age, we use normal saline rather than N by 2. Blood volumes are also different. Coming to susceptibility to infection and the use of antibiotics, there are different, up till in the neonate and up till the first 3 months of age, there are different organisms which are important and different choice of antimicrobials. The connotation of sepsis in a neonate immediately brings up that you, other than the blood culture, you have to do lumbar puncture, urinary infection. All of these have to be automatically evaluated if you're thinking of sepsis. A couple of lines about antibiotics and medication. Infants are G6PD deficient and we should not use sulfonamides or primaquine. Valproate is contraindicated below 2 years of age due to fulminant hepatitis. Doxycycline and tetracycline colors the teeth. Antimotility drugs are a no-no because they may cause paralytic ileus and may even be fatal. So these are some of the important things to remember. Those two lists in the intranet are very good. They give all the adverse effects and the doses also. Some ethical issues to talk about. Pain is an important issue, and there is a cream called EMLA cream or xylocaine, which we can put on the area 15 to 30 minutes prior to taking IV sample or putting an IV line. Consent is an important issue. When you have the foundation course on the ethics, it will be taken in detail, but below 18 years, the legal age of consent, you should have assent for older children. And research in children is a different issue. They are a vulnerable group, just like prisoners or pregnant women or anything. Children are a vulnerable group, and one has to be really careful while doing research on them. I want to end with telling the resource people in SGPGI, in pediatric gastroenterology department, neonatology department, and pediatric surgery department, all the people are very conversant. All of them are pediatricians and pediatric surgeons and very conversant with what to do for a baby or a child. In CCM, in critical care department, Dr. Banani Podar is the resource person, pediatric intensive care person. In genetics and pediatric endocrinology, there are many people who are students as well as faculty who are pediatricians. So please make use. And Dr. Piali Bhattacharya is the pediatrician in General Hospital. So please make use of all these people. The intranet has 2 easily searchable drug dose databases, as I already mentioned, and lists of antihypertensives, sedatives, anticonvulsants, and the BP centiles for quick reference. Thank you very much for your attention.
Thank you, ma'am. Unfortunately, we won't be able to take up questions. So I would thank you for taking the time and having this lecture. And I hope the adult physicians who are looking after patients in their own wards would be able to access these on intranet, or at least have a list of resource people whom they can approach if required. So we move on to the next talk for today. All these talks actually are just an introduction to a larger issue. So artificial intelligence is a big thing which will come up in our medical practice very soon. And it's been in progress. And to give just an introduction to this interesting topic, we have Professor Uday Ghoshal from Department of Gastroenterology, and I think he has planned a one credit course even on artificial intelligence later. So people who are interested could register for that course. And this would be just a glimpse and an introduction to this upcoming branch of artificial intelligence in medicine. Over to you, Dr. Ghoshal.
Thank you so much, Dr. Preeti. Can you see my slides?
Yes.
Yes.
Yeah, we can. And hear you also.
Thank you. So as Dr. Preeti rightly said, that we are going to give a concept to you. So we are just going to give a little glimpse of artificial intelligence as applicable to the medical science. So you will ask me, why am I talking about artificial intelligence to a medical gathering? This is because it is being used extensively in medical science. I have listed on the left side what all branches really had multiple application on artificial intelligence. But obviously this is endless. There are too many branches now. The branches include gastroenterology, GI endoscopy, hepatology, radiology, pathology, forensic medicine, gynecology, neurosurgery, dentistry, oncology, cardiology, dermatology, and you can name any branch. So what happens is, in fact, I tell you, artificial intelligence is a mathematical computer technology. Therefore, the medical scientists were quite late to accept it. Much before that, it was being extensively used in non-medical field. For example, in email communication, in social media, in web searching, in store and services, in banking and finances, aviation and prediction of machinery failure, maps and direction, war, criminology, and so on. So it was being extensively used earlier. For decades, the medical specialties took up this branch only in last 1 or 2 decades. Now, what is artificial intelligence? It is the ability to acquire and apply the knowledge and the skill. So if you go to Wikipedia and type what is artificial intelligence, this is what it gives. It gives that it is a capacity for logic, understanding, self-awareness, learning, emotional knowledge, reasoning, planning, creativity, critical thinking, and problem solving. This is too much, I tell you. So what happens is, artificial intelligence is the field of computer science that is associated with the concept of machine learning, thinking like human, to perform tasks such as learning, problem solving, planning, reasoning, and identify pattern. Somebody will tell you, this is absurd. Can computer learn? Can computer think? Can computer apply logic? Actually, as we go along, we'll realize it can. Now, this is an impression about people on artificial intelligence. And this is based on a survey in Great Britain in February 2006, so about 4 years ago. Now look at this, only about 18% accepted this to be an important branch. Others said mistrustful, powerless, anxious, indifferent, skeptical, and so on. So when we are talking about artificial intelligence, I know that reaction of all of us are likely to be similar. But you have to realize that as time is coming, it is being incorporated in multiple disciplines. So it is better to learn rather than being mistrustful. Now we'll talk about terms in artificial intelligence. The terms include artificial intelligence, machine learning, and deep learning. So remember these three terminologies: deep learning, machine learning, and artificial intelligence. Will give you the concept here. Let us look at a situation that in medical science, we read a lot of things, like let us say now coronavirus epidemic or pandemic is going on. So people will say, if somebody gets coronavirus, what is the chance that his outcome would be bad? Now somebody will say, it depends on the gender. Maybe female gender would do better than male gender. Somebody will say, it depends on the age. Maybe younger people will do better than older people. Somebody will say that it depends on whether you have comorbidities such as diabetes, hypertension, renal failure, heart disease, lung disease. If you have those comorbidities, maybe you will do worse. Now, how did we learn this? This we learn typically by statistical analysis. So we use a huge database, let us say 1,000 patients, 2,000 patients, 5,000 patients, 10,000 patients. And then you divided the people who had a bad outcome and those who had a good outcome. And then you looked at each parameter such as age, gender, presence of heart disease, presence of lung disease, and so on. And then you found out the p-values by univariate statistical analysis to say that is there a significant difference in the outcome, those who have bad outcome versus those who have good outcome. Is there a significant difference depending upon presence of these factors such as older age, such as male gender, such as presence of comorbidities, and all this. Now, how did you really analyze, or how did the statistical technology really analyze the data? This is done in univariate analysis and multivariate analysis, and typically in multivariate analysis, they talk about linear regression. Linear regression. Now, what is regression? The regression means a term that the term stepping back towards an average. What is stepping back towards an average? It is like somebody said that ultimately a child's height will depend on his mother's height and his father's height, and he will be between among these two. That is father's height and mother's height. The two together will determine the child's height. So therefore, let us say if somebody wants to look at body weight of a person in relation to height. So on the y-axis, you plot the height. On x-axis, you plot the body weight. And then you see, is there a linear relationship like this line? Obviously, you don't expect an exact linear relationship. So when you don't expect exact linear relationship, what do? You look at a coefficient of correlation. What is this? Let us say this fellow's height is here, whereas this fellow's height is here, and this fellow's height is here. So obviously, depending upon the value of this correlation coefficient is the value dependent on the distance between the actual value of that person's weight in relation to a total 100% linear relationship, which is plotted here. So basically, this correlation coefficient will be helping you to predict that if you know the height of that fellow, what would be the weight of this fellow. Now, what is the presumption here? Presumption here is that the biological data are supposed to be or would be linear. So you are presuming that all biological data would be linear. For example, like this, body weight and height, they linearly correlate. But look at this situation. If I say that, take another example, quality of life of a person is dependent on the body weight. So if somebody has a reasonable weight, that means he's healthy, his quality of life is good. So if we say quality of life depends on the body weight, what you will see is that a fellow who is very malnourished, he will have a poor quality of life. Now, as his nutrition increases, his quality of life will be better and better. But at a certain point, when he starts becoming obese, his quality of life will become again worse. Now, if you do a linear regression here, it may not show any relationship because this data is not exactly linear, as you can see, that the quality of life of malnourished is poor, the quality of life of obese is poor, but the statistical technologies cannot adapt for this linear, nonlinear relationship, because all the presumption here in the linear regression is the data are all linear, it cannot be nonlinear. Now, therefore, what is the way out from this? Look at this bicycle. The bicycle has a chain which is made up of iron. Can you see this iron? And the iron is typically linear. That means it is straight. You can't really flex it. You can't really bend it easily. But let us say if I join multiple such pieces with screw, it becomes non-linear. That means now, though it is made up of iron, it can bend and it can do the job what it is supposed to do in bicycle. Can I do the same thing with the data? Yes, we can. And this is the nonlinear modeling, which is the concept of artificial neural network or the artificial intelligence or the machine learning. Now, what happens is this is inspired by the structure of the human brain. We all know that human brain, that we have the afferent system or afferent nerves which give input to the brain. Now, after that, we have forebrain, or rather the whole brain mass, primarily the forebrain, which does a lot of association work, lot of judgment work based on the data that it has. This data is based on the learning from our childhood. Like we all know that this is what I have to do if I face this situation. So if there is a fire, I have learned from my childhood that I have to put water there. Maybe I have to call fire brigade. So this is all learned. This is all data which is stored in our brain, and this processing is done in the brain. But the afferent comes from that setting up of the fire that happens. Therefore, the artificial intelligence system is similar. What it does is, let us say you have all these input variables. Like I gave an example of coronavirus outcome. The input variable was gender. Input variable was age. Input variable was maybe blood sugar, maybe HbA1c, maybe presence of diabetes or no diabetes, maybe obesity, maybe presence of cirrhosis of liver, maybe presence of cardiac disease, maybe presence of lung disease, and so on. So these are called input variable, something like afferents. Now, each of these input variable, its value will give a forward propagation. And then you can see the box here. What is this box? This box is nothing but a regression equation. This regression equation is, let us say input A is here, let us say age. Let us say input B is here, let us say this is comorbidity. Let us say input C is here, let us say presence of, let us say heart disease. Now all these input variable, when it takes the data from here, it actually influences this regression equation. The regression equation is, let us say input A into W1. What is W1? W1 is the correlation coefficient value which is used in linear regression. Input B is here and into W2. So what is this W2? W2 is actually the value of correlation coefficient that we get from the regression equation. Now what happens is when this input A into W1 plus input B into W2 crosses a particular threshold value. You'll say, where did you get this threshold value? I'll tell you later. Then this regression equation actually influences the next layer of regression equation. Now the same thing will happen here, and from there output will happen. Now let us say the output is this patient did not have a good outcome. Let us say this patient did not have a good outcome. This is what the network predicted. But when the network predicts, you have to do a supervised training of the network in the initial phase. Let us say you have data of 1,000 patients. Let us say you take 500 patient data to train the network, and the initial phase of the training, you tell the network that what happened to that patient actually. Now, let us say network predicted this patient had a bad outcome, but actually you gave the data to the network, the fellow had a good outcome. So the network will realize that he made an error. And when he realizes he made an error, he will back propagate. The network will back propagate and adjust the threshold value here. The threshold which gives an output to fire to the next level. So adjust the threshold value here. And what happens is, that is how the network learns. The network learns by back propagation and correcting the threshold values. You can see from here that it typically or it classically mimic our human nervous system. It is the synapse is here. Synapse is this regression equation. And I gave you the example of bicycle chain. In bicycle chain, what we did is we take all these linear pieces and connect it by a screw. Now here, this is the screw over here. So the network keeps on learning by back propagation. So therefore, artificial intelligence, I told you three terminologies: machine learning, artificial intelligence, deep learning. So artificial intelligence is computer program that mimic human cognitive function such as learning and problem solving. Whereas machine learning again is a computer-based method for analyzing the data. The program is artificial intelligence. Machine learning is the process of analyzing the data. And lastly, deep learning means it is machine learning method based on complete complex architecture of artificial neural network. That means machine learning and artificial intelligence together constitute what is called deep learning. Now look at here. This network, which is the very conventional network that we use, is called multi-layer perceptron network. Why? Because this has multiple layers. This is layer number 1, this is layer number 2. And each layer, what does it do? It percepts. It tries to understand what would happen to the patient, what would be the prediction. So that's why it is called multi-layer perceptron neural network. Okay. Now, this requires machine type data. If machine has to learn something or interact with each other, let us say one X-ray machine is interacting with another X-ray machine using artificial intelligence, it requires machine type data. So machine type data are actually typical mathematical data. So therefore, if you are talking about an imaging technology will give you pixel, it will give you voxel, it will give you pattern. All these will be converted to machine type data. And therefore, it is possible, let us say one company markets a machine, and these machines are all connected through artificial intelligence. And let us say you do use this machine in SGPGI, all the data would correct another machine present in Singapore. It is possible, but only there is an ethical issue. The data sharing would not be allowed by us. That's why this level of artificial intelligence did not progress, that one machine is learning for another machine or learning from another machine located elsewhere. Now, since I'm a gastroenterologist, I'll give you some example of artificial intelligence in which we have worked. Now, let us look at this. We see patients with ulcerative colitis. Now, ulcerative colitis patients are the one who, about if you have 100 patients of severe acute ulcerative colitis, about 15% of them would not respond to medical treatment. So these 15%, once upon a time, would straight go to the surgery. Now, let us say if I admit 100 patients of ulcerative colitis today to our ward, every patient will like to know that am I likely to respond or not likely to respond. Even I will like to know whether they would respond or they would not respond. Because you know why? Because patient will prepare for the surgery. Patient will mentally like to prepare for surgery. My surgeon will like that I correct all the malnutrition, electrolyte imbalance, low hemoglobin, everything. Also, there is an emotional feared for against surgery. So therefore, we have to counsel the patient. So obviously, in day one, if I can tell this patient is likely to respond or not likely to respond, it will be good service to the patient. So this is what we did in 2004. 55 patients, 45 were responder, 10 were non-responder. We did a simple univariate analysis, and you see age determined response, pedal edema determined response, transverse colon diameter determined response, low hemoglobin was associated with poor response, and so on. Now, what is this technology? This is univariate technology. Let us say it is possible that a fellow who is, let us say, female gender would have a lower hemoglobin. So if you take hemoglobin alone without consideration for gender, actually you may make a mistake. Maybe female patient did not respond to so well, and you thought it is low hemoglobin which led to non-response. This is because female patients have a lower value of hemoglobin than a male patient. Obviously, we would like to do a multivariate analysis where each of these factors, that is hemoglobin adjusted for gender, hemoglobin adjusted for age, all those we want to do. So this is what it is. Predictor variable can be all this. Dependent variable is typically categorical. But I told you, this type of analysis has a limitation. What is the limitation? This is the linear modeling. Also in multivariate model currently, what science says is only those variables which are significant. By univariate analysis, you enter those into multivariate model. So what happens is if you have a small number of patients who were elderly in that particular study, so it may not find significant, though there is a significant difference that older people would not do good as compared to the younger people. But because your old people with old age was very less, this did not have sufficient power to actually come significant in univariate analysis. So that's why only variables significant by multivariate analysis, univariate analysis entered into a multivariate model is a tremendous limitation. Second is when you do an univariate analysis and even multivariate analysis today, 20 years later, this may not be very good system. You know why? You have developed a system today and you found out that these are the factors which are associated with poor outcome. Let's say in 20 years time, actually science changes so much that all those factors may become less important, but you keep on using those scores in the medical science when the scores is 20-year-old or 30-year-old and the scores did not continue to learn like human brain. What is the advantage of artificial intelligence? It continues to learn from forever. So therefore, the univariate analysis and multivariate analysis has limitation, have limitation. This is like a few blind men and the elephant story. Now, this is one of the study that we published just recently. Now, initially we started with this 50 patient. Now our number went to about 270 patients over 12 years. And now in this particular model, we not only use univariate modeling, we did not only use multivariate modeling by this technology, which is called principal component analysis, which is the technology of multivariate analysis today, but we use an artificial intelligence modeling, which is a non-linear modeling system. So artificial intelligence, as I explained to you, is a non-linear modeling system. If the biological data is non-linear, which is likely to be the case most often, it will still continue to learn. Now, this model we have been using in 2003, also we used these models in cirrhosis of liver. Now, what is the limitation of artificial intelligence? When we are talking about artificial intelligence and we are telling everything is good, so you say, what is the limitation? Is there no limitation? The limitation is called overlearning or overfeed. What is overlearning? What is overfeed? Let us look at our typical entrance system through which you have come to do MD or DM in SGPGI. So let us say lakhs and lakhs of children appeared for an MBBS entrance. Now we selected them based on all those MCQ. Now then again we had an exam, MBBS exit exam. Now then we took another exam. This is called MD entrance exam. Then again we did MD exit exam. Then again we did DM entrance exam and DM exit exam. What are we trying to do? We are trying to create students who are very capable, who are very knowledgeable, who are very smart. So therefore, this is like artificial intelligence. You are passing them through multiple layers. Okay, it is like a multi-layer perceptron network. But let us say what I do is that whenever somebody enters into the courses, we teach them 1,000 MCQ. Months and months, years and years after, we teach them 1,000 MCQs. And now what will happen is that these children will do very well, like let us say all these SGPGI children, or let us say all the KGMU children, KGMU students, they would do very well because we taught them MCQ, 1,000 MCQ. And then this 1,000 MCQ are used to test all of you. What will happen is you will do very well, but this is called overlearning or overfeed. You have learned those 1,000 MCQ again and again, and we have tested you with those MCQ again and again, and this is an overfeed. Now, if this fellow goes to another system and he will not perform well, he will perform very poorly. So therefore, all the artificial intelligence modeling that you see, particularly the multi-layer perceptron network, if you use the same group of patients, like let us say 1,000 patients treated in SGPGI, 500 used for testing, 500 used for training, and you saw that this network performed very well, it actually learned everything from the same group of patients which it is going to interpret. So therefore, it is an overlearning model or overfeed model, and this is not robust enough to perform reasonably in the real environment. So this is overlearning. That's why it is recommended all the artificial intelligence technologies should be tested in multiple systems. This is called internal validation when you test them in your own patient, external validation when you go to another institute, maybe another country, and all those. These are important. Now let us talk about, till now we talked about multi-layer perceptron network. Multi-layer perceptron network is the network which is typically used for prediction of outcome. But when we are talking about all these imaging science, for example, I will take an example of GI endoscopy because I am a gastroenterologist, I am an endoscopist, but we all know what are the sciences that deal with imaging. So that network is totally different than this network. Let us say that network is called convolutional neural network. Convolutional neural network. Now I'll give a simple real life example. Here is a photograph. This photograph have been uploaded in the Facebook. Now you will see that the moment you upload a photograph, actually what the Facebook does is it immediately recognizes some of the person by their name. How did the Facebook do that? Facebook has learned using artificial intelligence technology the pattern of image of that person. If it sees that this is the voxel, this is the pixel, this is the curvature in different places, this is the color of the different places in the face, and repeatedly many members in the world kept on uploading this particular image and kept on writing this particular name, this back propagation happened in the system, and therefore it learned that if it is the voxel, if it is the pixel, if it is the pattern, if it is the color, if it is the texture, this fellow has to be this fellow because it got associated with that particular image pattern with that particular name. This is called convolutional neural network. What does convolutional neural network do? Convolutional neural network typically work through multi-layer perceptron type network. But what happens is it further adds to pattern recognition. It adds to pattern recognition. Also, it works like all these I told you machine type data. So if you got voxel, you got pixel, all these data are converted into number, which is what machine can actually read. And this is an additional network, which is beautiful. And obviously, I can't get into convolutional neural network work. We need more computer scientists to work on the convolutional neural network. And there have been several models to use it. One of the model which is very popular now is called GI Genius. What GI Genius does is that whenever a colonoscopist is doing colonoscopy, people tend to be tired towards the evening of the day or afternoon of the day. because throughout the day he's doing endoscopy, he becomes tired, and when he becomes tired, he tend to miss the subtle lesion like this. And what GI Genius does is that there's a convolutional neural network inbuilt within the system, and it gives you a box like this green box, and it says, look here carefully, there is something which you may be missing. And there are studies to show that if you use a GI Genius, it actually improves your performance, it reduces your error rate as far as detection of this is concerned. We all know capsule endoscopy, but I think I'm going to overshoot my time. Dr. Priti, am I overshooting my time? Dr. Priti?
Yeah, yes, Ghoshal. Actually, Aditya also has
Yeah, so now we stop here. Just I get the end of it. Now, this is what is called big data. Artificial intelligence has an advantage to read big data. Like in research, we use artificial intelligence extensively to handle big data. For example, when you do gut microbiota study, you get tremendous amount of big data, and this can be used, handled by artificial intelligence. In genomics, in proteomics, lot of places where you have sort of huge amount of data to process the data. Artificial intelligence is the technology today. And when you do journal club, you'll realize wherever there is a big data, they talk about artificial intelligence for the analysis. So therefore, I tried to give you a concept. Let me conclude. Artificial intelligence is a promising technology for all branches of medicine. So there is a saying in the, there is a quote which says that those who think they have learned everything, they don't exist in the world which cease to exist. That means if you think that you know everything, then you are living in a world which does not exist. So you have to continue to learn. So therefore, if you say, I don't accept this is a mathematical technology, I am a medicine fellow, and I don't like mathematics, you will become old very quickly. So it is good time to catch up this. And best way to catch up things is go beyond your science, that cocoon type situation, where you first get into medicine, then get into a specialty, then get into a tool, and stop seeing around. See around, look around, talk with other scientists, such as mathematician, such as chemist, such as computer personnel, such as mathematician. Thank you so much.
Thank you, Dr. Ghoshal. I think students who are interested have got a glimpse of what actually artificial intelligence can do in medical science and our profession. In our profession, we have a lot of relationship with industry in various aspects, be it academics, be it developing research tools, or for developing treatment modalities. So what should be the academia industry physician relationship? Professor Aditya Kapoor from Department of Cardiology would give you an overview of this topic. Aditya? Aditya, you're visible, audible.
Okay. And Ghoshal, thank you for, I think that was a brilliant eye-opener. Compliments. It was really a nice lecture. And as Dr. Ghoshal, in his last slide, he said that, we need to interact with so many people, and we need to interact with industry as well. So thank you, Dr. Preeti, for giving me this topic. It's probably likely to be more of a philosophical talk. I have some evidence, but it's more of a philosophical bent. So we'll just discuss the following issues. Why do we need to focus on this? How does the industry actually collaborate with doctors? Do we need to take any steps to work towards this relationship? Are there any theoretical legal sanctions in place? And what is my take on this? In conclusion and messages, what is my opinion on this? So why, first of all, focus on this? We all know that medical profession, patients and industry, they have a unique relationship. The industry makes products which it cannot sell directly to the patient or the consumer directly. They need the medical profession to do that. And we as medical professionals cannot treat the patient without drugs or without devices which are sort of manufactured by the industry. So theoretically, both industry and medical profession have a common name. They are interdependent, and the common name is patient benefit. And these collaborative settings, whenever you collaborate with somebody, it's a fertile ground which is a proactive ground which takes you forward, but it is also a ground which can lead to conflicts. And in fact, this is not a new phenomenon. In fact, NEJM in 1980, that is nearly about 40 years ago, actually had a superb article which they labeled it as a medical industrial complex or the industry physician relationship. And they said that it is necessary to ensure that the medical industrial complex or this relationship puts the interests of the public or the patient foremost before that of the stockholder. And the stockholders are primarily the industry and of course the medical profession. So it's a two-way benefit, any interaction. What are the benefits to medical science? Most of the interactions, I believe, if done in a healthy manner, they are beneficial to science. If you look at research innovation, which Dr. Ghoshal also talked about, most of the research innovation will happen in clinical settings, in labs, in hospitals. And only after the physician or the doctor collaborates with the industry will that research translate into any clinical benefit for the patient. So, even if you do a research and the doctor or the physician does not use it, it is not going to be of any patient. What is the benefit to the industry? The industry frequently cultivates relationships with doctors because we fortunately are in a position to generate business for them. So I don't mean that in a bad manner, but of course, it's a true, which is a statement to make that we as treating physicians are in a position to generate some business for them. We are gatekeepers to all patients, and any access or influence which we can sort of exercise over patient or their management practices is considered a good investment by the industry. So that we have to keep in mind. Positive relationships with the industry does result in use of more products. So that is again a true statement. We should realize that if we interact with them in a positive manner, obviously it is a healthy relationship for them because it will generate more business. So although mutually beneficial, these lines can get blurred sometimes, and a potentially theoretically ethical relationship can deteriorate into a conflict of interest due to various things: honoraria, compensation, writing about company products, payment for research trials, and of course, gifts. So we'll discuss all these issues and all these fringe benefits, if you want to label them as such. They are often dictated by the medical hierarchy, the specialization, where is the location of your practice, whether you're in solo practice or in group practice or in government practice. So we'll just briefly touch upon those points as well. And often what happens is in medical curricula, these things are not taught to us. So we learn as we go along. So it's, I think Dr. Preeti, Dr. Amita, whoever has designed this course, this is a good topic to have. Does a relationship actually exist? We all know it does, but what is the published data? So this is a study which I pulled out from NEJM about 15 years ago in the West. 90% of the physicians reported that they had some type of relationship with the industry, which is what we also see, either in the form of drug samples or gifts, reimbursement for professional meetings or CMEs, consultancy, lecture fees, enrolling patients in trials. So in order of frequency, this was the type of relationship which was reported. Physicians in solo or group practices are more likely to be involved in industry relationships than hospital-based practice, because often institutions have their norms, their protocols, and in solo or group practices there is more independence or more flexibility. And this entanglement has led to a fair degree of commercialization, both of clinical medicine, patient management practices, and research. And that prompts a closer look to see if any of these interactions, which honestly should be useful for the medical fraternity, can they become harmful? So how does the industry collaborate with physicians? There are various ways. First and foremost is, of course, a visit to medical students, doctors, which the medical reps do, CMEs, research fellowships, journals, publishing journals, conducting trials, and involvement with professional societies. So again, we'll briefly cover these points because these are important things to just remember at the back of the mind. Intuitively, we all know about this, but it is important to discuss. Interestingly, the industry spends about billions of dollars annually in marketing samples or devices to physicians. On an average, 4 to 5 times a month, a medical rep will visit the physician. And the industry's perception is that if they give information favoring the sponsor's product or the device or the drug to the doctor, it will theoretically increase the likelihood of prescribing that product. However, information exchange in these interactions by the medical reps to the interns, to the doctors, to the consultants, it is not always correct, it is not always ethical. Published data shows that often the information is more than promotional. It often fails to reside within regulatory guidelines. So it is up to us how to process that information. So, they tell us something, we don't have to take them at face value. And if we do that, if we are not observant about it, our prescribing patterns may become inconsistent, non-rational. We might start using non-generic drugs. We might start using second choice drugs, which will of course increase the cost to the patient and comes at the risk of increasing adverse effects as well. So, whatever information we get, it is up to us to process it in the right manner. What are the perceptions about medical reps amongst patients, medical students, senior doctors? If you see again, this is interesting published data. When patients in cancer medicine, surgical practice, cancer trials, they were interviewed, they said that most of them believed that the relationship would be beneficial to patients because inherently the patients trust their physicians to have their best interests at heart. So we should always, respect this part, and we should always prescribe and use the information presented to us by the industry in the best possible manner. Medical students, what is the perception? Exposure starts in medical school to medical reps and to the industry, and it can influence our prescribing behavior. And this is again published data in JAMA and International Journal of Pharmacology amongst interns and medical students. Most of them thought that company material was useful. It was a good way to learn about new drugs. But most of the younger guys were also perceptive enough to believe that reps always exaggerate the benefits and downplay the risks. Many of them also believed that gifts would not influence their practices. So we are very sure about what we want to do. And if we are confident about what we want to do and do it in an ethical manner, it is unlikely to influence our prescribing practice. What about senior doctors? Interventionists always feel that their interaction with the industry is different from that with the physicians, because a surgeon feedback is more useful to improve the device or a procedure, as an angioplaster or as Dr. Kushal mentioned, as an intervention gastroenterologist, whatever feedback he'll give to the industry is likely to improve the technology of the so-called device in question. Physicians advise more often to recommend alternative modes of treatment or to recommend which is a better drug to use. So 60% of the physicians believe that incentive did not influence their own practice. But surprisingly, only 1 in 6 believe that it was true for their colleagues. So we have more faith in ourselves rather than our colleagues. And this is what is called the theory of unique self-invulnerability. We have more faith in ourselves rather than in our colleagues. Things like drug samples, non-educational gifts, journal reprints, sponsored workshops, CMEs, registration fee for conferences are often perceived in the West as things which you can sort of avail of from the industry. But the things which are marked in blue are a big no-no. This is published data, so we'll discuss what should be the ideal way. Most doctors believe that it is important to have rules on industry interaction in hospitals. And this, if there are no protocols, there are no workshops, there are no guidelines, as I said, irrational prescribing, altered prescribing behavior will happen. That is why policy implementation is. How does the industry get involved in CMEs, research fellowships? We all know nearly 2/3 of all CMEs across the world are sponsored by the industry. So that is whether you want to accept it or not, that is the truth. Professional medical associations have often endorsed industrial products. In fact, this is a funny data. The American Academy of Family Physicians actually at one time point of time collaborated with Coca-Cola to support patient education materials on obesity. So this was a huge paradox. It's been corrected then, but that is what has happened in the past. Industry often funds a lot of biomedical research. If you look at cardiology, without industry, there would be no statins, no drug-eluting stents, no devices. And funding into research may become even more industry-sponsored funding as the government decreases its commitment to basic and clinical research. So this is happening in the West, where NIH-sponsored trials are coming down and industry-sponsored research is going up. So how to ethically manage that, we will discuss shortly. And lastly, how does the industry get involved in journals, trials, professional medical organizations? So a lot of journals are funded by the industry, publishing charges, supplementary issues, online free subscription is given to members, advertisements. In fact, if you look at the BMJ USA, $90,000 per month is paid for fully by advertising from the industry. And medical journals and industry, they are uneasy bedfellow. This was a great editorial which you all should read at some point of time. It will encourage a bias. The educational usefulness of such journals or such data is questionable. Industry supported research, we all know, will favor the industrial product. Industry sponsored reviews are always under scrutiny. Unfortunately, no definite guidelines are there in place for journals how to manage that. What the BMJ does, I'll describe shortly. How does the industry get involved in conducting trials? There are seeding trials with the company just conducts these trials simply to get doctors to prescribe their drug. And investigators are often ordinary physicians, researchers, they get paid. There are switching trials where patients are just switched from one drug to the another to encourage doctors to write the new drug. Doctors are often paid large sums of money. So one should not get involved in such trials. Industries are involved in budgeting various professional organizations. The industry is very visible at society functions. Often it is done to gain favor with the leadership to get the product into industry, into professional guideline endorsed products. So some trade-off is definitely going to happen when the industry funds these societies and gets involved in shaping up the guidelines. Again, published data, financing of drug trials by companies and its consequences. The same data gets published, negative data does not get published, and ghost writers who are supplied by the companies are often used to write the results of these trials. In fact, this is data from Germany. Gabapentin data was manipulated at a certain point of time so that the drug could come into the German guidelines. Similar data for psoriasis, it happened that industry-sponsored drug was incorporated into the guidelines. In fact, at some point of time, erythropoietin was also included in the KDO kidney guidelines, and Amgen was the main founding and principal sponsor of these guidelines, and Amgen was the main manufacturer of erythropoietin. And again, it happens in cardiology also. Now if you see the guidelines, statin and ICDs, they are being endorsed by the professional societies to use them across the board. So there is a lot of industry permeation into these guidelines. What are the steps to be taken? For CMEs, we can have a central depository where the funds can be utilized for various accredited programs. The scientific content should be controlled by the societies. Company control presentation should not be encouraged. What the BMJ does, I said that it is funded by advertisement, but again, the editorial team does not attempt to review the claims. The readers are encouraged to criticize the advertisements, and they are even encouraged to complain to the authorities if they think the information given by the industry is wrong. So that is what good journals do. For trials, no company rep is allowed to sit on the executive committee of the trial. The participants or the trialists obviously do not accept any industry honoraria or declare the conflict of interest at the outset. The data is confirmed by external academic sources before it is published. And the trialists at all times have access to the database. The industry does not have access to the database or any right to publish the results. And of course, industry funding is mentioned in the patient information booklet. So these are the ethical ways in which you can do a trial and at the same time reduce your conflict. Legal sanctions, the US passed the Sunshine Act, which you all should be aware of, which mandates the public disclosure of payments to physicians by medical companies. In fact, it is made public. All this consulting, honoraria, grant, research, all these things is in the public domain in the US. Again, the Sunshine Act does not prohibit collaboration. It only ensures new compliance requirements. And it simply makes the data available to the public. So there are some sanctions in place. And all these things are exempt in the Sunshine Act. Small payments, education material which benefit the patients, expert witness fees, samples. So these are all exempt. What the MCI tells us, we should not accept gifts, travel facilities, hospitalities, cash, monetary grants. They should not be taken by the doctors. Research, if funded by the industry, has to be cleared by the relevant ethical committee. As I mentioned, funding should be publicly disclosed. Freedom to publish the results, and you should have such clauses initially inserted in the MOU. I think Dr. Kushal, if he is there, he can tell us more about this. And we can work as advisory in the advisory capacity with the industry, provided professional integrity and freedom is maintained, patients' interests are not compromised, and affiliations are within the institutional law. We should avoid endorsing any drug product publicly and maintain our professional autonomy. So this is what the MCI tells us. However, too many restrictions, I believe, can hurt this collaboration. So I'll conclude by saying that, in the West also it has been shown that these legal sanctions are having an unintended impact. Young doctors who want to say positive things about the industry, which there are some positive things to say about this relationship as well, they want to remain anonymous because they think that it will affect their careers. Fear of getting branded or discredited if you speak positively about the industry. We are worried about what will our colleagues say about us, what will our patients say about us. So that is a bad impact which these sanctions are having. In fact, in the US, where Massachusetts, where this act was initially brought about, conferences have markedly curtailed. Visiting professor programs which were funded by the industry, PG programs, have been cancelled across the board. So this legal sanction can impact future innovation and development as well, because sponsors are shying away to take part in medical research. In fact, the Newsweek magazine published in 2010 that the American public is concerned and is saying that if too many restrictions are placed on interaction between physicians and industry, it can reduce innovation and production. So my take on this is that medicine today is very, very technology dependent. Research, education, quality improvement is the need of the hour. Industry provides us a degree of scientific and technical support, but it also gives incentives that can potentially influence our choices. So we need to have more such workshops so that we can develop guidelines, we can brainstorm, we can understand from each other across the board, seniors and juniors, how should we manage this relationship. At the level of the regulatory bodies, we should have guidelines by the institutions. For instance, MCI, not many are aware of these rules. In fact, the industry will never tell us about these rules. So we should make these MCI rules more visible. Johns Hopkins has these policies in place. In fact, site access by reps is strictly regulated, which should be done in our institution also. So that all of us encourage and interact with the industry in a focused way without any personal benefit. We can disclose our conflict of interest. If we are taking honorary or consulting fees according to the institutional norms, many people donated to charities run by the parent society. It is difficult to set a monetary value which will render a gift unacceptable or untenable. What my impression is, always think what is the purpose of the industry offer, what would my peers think about this arrangement, what would my patients think about this arrangement. So these are three moot questions which you have to answer at your own personal. Remember, our reputation is driven by what our peers and what our patients will think about us. So I honestly believe healthy relationships can exist between the industry and the doctors. We have to be crystal clear in our mind what our relationship is. Nobody can tell us that. We have to be, define that ourselves. And this relationship should never erode the trust the patient has in us. So the answer is not a collective industry hug. We should not become completely tied to industry support. I believe transparency is the key. Ethically managing industry physicianship relationship is possible, and it might help better than potential threats of sanction. Thank you. Thank you. I think I overshot by 2 minutes.
Thank you, Aditya. If there are any questions, we could have a couple of them. Aditya, you have that much time?
Yeah.
Yeah. So does any one of you have any questions? Can't see any hands raised or anything. Or I'll just check the chat box. You could type it in the chat box also if you have. No. Thank you, Aditya.
Thanks. Thank you.
We will move on to the third talk for today. That is, what are clinical trials? We talk about that this is a randomized double-blind control trial and those kind of things. So what are these trials which help us decide treatment or help us understand that which is the best way to treat a patient? So to give an introduction to these clinical trials, we have Dr. Sudeep Kumar from Department of Cardiology. Over to you, Sudeep.
Thank you very much, ma'am. Yeah. See, after a wonderful lecture of Dr. Adit Kapoor and artificial intelligence by Dr. Ghoshal, now I will be taking you to the nitty-gritty of these clinical trials in an overview manner. So why this is important? Because we often present journal club and we come to the terms, as Madam mentioned, double-blind randomized control trial. What is blinding? What is placebo? And why it should be done? So I will be discussing these in the next 30 minutes. Probably I will not overshoot. So my plan of discussion will be just what is the biomedical research, what are the types of studies, then I will what are the of the observational studies, then how to overcome by randomization and blinding, then what is the utility of the placebo, and the newer term which you will come across is the nocebo effect. I will discuss as brief, and then various design, and then I will take you through the various phases of the clinical trials in the drug trial, and then like to summarize after that. So we know that the biomedical research, this is the area of the science devoted to the study of the process of life, and basically for the prevention and treatment of the disease and the genetic and environmental factors related to the disease as well as the health. So basic research, it has a two part, the basic research and the applied research. And the clinical research uses the knowledge of the basic and as well as the applied research for the conducting a research for the treatment of a disease or a dysfunction in a new way. That is the definition of the clinical research. Design overview, what we know that there are basically two types of major design. You have already told by our biostatistician colleague about the types of design, etc. So basically there are two types of design. There's observational studies and the experimental studies. What is the observational studies? Where we'll observe the exposure as well as the outcome simultaneously. For example, if you want to see how many how many smokers are having coronary artery disease, so I will just collect the data of the smokers and do some tests and find out how many smokers of them are having coronary artery disease. This is observational studies. And then studies is when we certain exposure. It could be a drug, it could be just a management protocol, or it could be a new device, whatever it is. We assign exposure to a group and then we observe the outcome. That is experimental studies. And experimental studies is also known as the clinical trials. So observational studies, if you go with the simplest observational studies, is a descriptive studies, which we come across in journal is a case report. When you come across as a different type of presentation of a disease, or if you have done something new, then you report to a journal as a case report. And if you've done few more cases, something like that, and you have observed similar type of presentation in few more cases, and then you present as a case series. Then these observational studies could be a cross-sectional studies, as already discussed. You just take out the survey. You take out the, for example, you just survey a school, middle school, and then you found out how many of children are having dental caries. This type of studies are known as the survey study or observational study. And then you can have a retrospective case control study, meaning by that you patient, you study the risk factor among the coronary artery disease patient, and then simultaneously you study patient without coronary disease, the risk factor, and then try to find out what is the difference between these two. And then I will like to discuss about the experimental studies in little detail. So I will go against. So what are experimental studies? These are the clinical trials. By definition, you know that what is a clinical trial? This is a medical research or any research studies where we determine the new drug or new treatment or new protocol or new device is safe and it is effective. That is the motto of the clinical trial. And if you do that clinical trial, then what is the definition? It is an investigation on human subjects intended to discover or verify about the pharmacological PKPD. Sorry, my phone is ringing. So you verify by its pharmacological property by PKPD study, meaning by pharmacokinetics and pharmacodynamic study. Then you verify the clinical effects of this investigational product, and with an objective also to ascertain whether it is safe or it is efficacious, and then you will like to monitor its adverse effects caused by this new investigational product. Basically, you try to answer in a scientific way whether this new drug, device, or protocol is working or not, or whether it's beneficial or not. So the types of clinical trials, it could be a treatment trial where you test a new drug, device, or protocol for most effective treatment of the patients. And then it could be a prevention trial. A simple example is the vaccine, where you test the vaccine versus a not a vaccine, and then try to find out whether the disease is being prevented or not. And then you early detection trial, where, for example, you try to do a CT scan of the patient and try to ascertain the calcium score in coronary arteries, coronary arteries, and try to ascertain whether the patient is having coronary artery disease or not. And then the diagnostic tools, whether that is efficacious or not, what is the sensitivity, what is the specificity, that is also comes into the clinical trial. And then the quality of life or supportive care type of clinical trials, where you suppose in a patient who is terminally ill, then you give certain new therapy and try to alleviate his suffering, improve the quality of life. That is also a type of clinical trial. So why observational studies are not treated as gold standard? We come across that the double-blind randomized control trial is always a gold standard. So why observational studies are not treated as a gold standard? Because of the bias and variability. So what is the bias and variability? Bias it affects the accuracy, whereas the variability affects the precision of that trial. So what is bias? Bias is any influence which acts to make the observed results non-representative of the true effects of the therapy. For treatment and to a sicker patient, obviously treatment A will appear to be superior to the treatment B. Now, another type of bias system, then if you think that patient or physician thinks that the treatment A is new and it is going to beneficial, it is very exciting, then he would like to take care of that patient in a better way, and that leads to the bias. There are other many potential sources of bias, and then comes the variability. variability is that there is a variability. It makes the accuracy of the observation less accurate, and it will be more difficult to discern the difference in the treatment. And the sources of variability could be a measurement or could be biological. For example, if you this measurement, for example, instrument variability could be there. For example, you are conducting a antihypertensive drug. If you are taking an antihypertensive, and then the variability comes to that some staff or some nurse or some doctor could be using the mercury manometer, some could be using the Android instrument, some could be using this electronic instrument. So there is a large variability among them. We know that Android is not a good instrument, and mercury manometers are phasing away. Now the gold standard remains the electronic instrument. And then the observer variability. For example, it is well known that in a doctor clinic, when the BP is taken by nurse outside room of doctor, it is always less than the BP measured within the room by a doctor. It is well known, and we know that the home measurement of blood pressure is always less than the office measurement. And then the biological variability within the individual. The same example, the blood pressure. If you take blood pressure in the early morning, it will be less, and it will take the blood pressure in the afternoon, it will be more. And then between the individuals, obviously, if you compare the blood pressure of an 18 years old boy compared to the 75 years old man, there will be marked difference in the blood pressure. We know that almost 30 to 40% of the individual more than 50 years become hypertensive. So obviously, we cannot rule out all types of variability, and we also not like to take out all the variability, because if you are testing antihypertensive, we would like to take the patient of 18 years old as well as 80 years old, and it should be working in both extreme of the ages. So whenever you are comparing between the treatment versus not given treatment or different treatment of that group, has to be a comparable. That has to be alike in all the way except the treatment being given. That's how the results of the intervention will be more authentic, will be more pronounced. So how to make it more comparable, the groups which we are assigning treatment, how to make them more comparable? That is done by randomization. Randomization is the allocation of treatment to participant is carried out using a chance mechanism, so that neither the patient nor the physician know in advance which therapy will be assigned. This is a chance association. So every patient has a fair chance, has an equal chance to be assigned a new therapy or not a new therapy. So equal chance. The simple randomization is just just tossing a coin. Head, you assign a treatment A, tail, you assign a treatment B. By this manner, 50% of will be assigned to the treatment A and 50% will be assigned to the treatment B. But this is not the way which we use, or not the way where the investigator used. Nowadays, the computerized random number generator is used, and we often used, or rather investigator often use IVRS or IWRS. What is IVRS? Is interactive voice responsive system or interactive web responsive system. So these by computerized manner, we randomize the patients. The problem with the simple randomization comes in certain way that if you are testing a drug which is being tested for the osteoporosis, and we know that the patient of more than 60 years of age having a more chances of osteoporosis. If you randomize these patients in 50-50 or manner, so sometimes it may happen that the age more than 60 years of patient will more in the one group and less in the other group. So drug will be supposed to be less effective in the patient in the group which were having more than 60 years of patients. the more number of the 60 years of age of patients, they will show a less efficacy of that drug. So how to overcome this? So that is done by the stratification. In this example, what we do, we just stratify patient into less than 60 years of age and more than 60 years age, and then randomize patient further. So by this manner, more than 60 years of age will be randomized into the two, and the less than 60 years of age will also be randomized in the 50-50% manner. That is known as a stratification. So sometimes it is not possible to randomize for each and every treatment. For example, statin. We were talking about the statin. Now the statin is recommended as the class 1 indication for coronary artery disease. And now if you want to test any other lipid lowering drug against statin, that will be unethical. You cannot stop statin of any patient who is suffering from coronary artery disease. So it is unethical, and sometimes it is not practical also. Suppose you are performing a new type of surgery, then it won't be possible that you have to randomize the patient it is not possible that. So what will you do? You take historical control, meaning by if you are having a new protocol or new drug, then you try to compare the results with the other trials, other studies available. The outcome from that study is to be taken as a control. And then you can use a non-randomized concurrent control, meaning by suppose you are using a certain new procedure, and then you can compare with the patient under not going that procedure in the same manner, uncontrolled manner, and then you can have a different treatment per physician. Suppose you are doing one type of procedure, then other physician is not doing the procedure, then you can compare the results. And then there's systemic alteration of the treatment. Suppose from 2016 onwards, I am doing this procedure, then I can compare the results before 2016 and after 2016. That is how you can have alternative to randomization. Another concept comes the blinding. Why it is important? I will come to know. I will let you know. And then masking the identity of the assigned intervention is known as blinding. Why it is important? It is important because you have to avoid potential bias caused by the conscious or subconscious factor by physician or by patient himself. Single blinded study, meaning by the patient is not aware of the assigned treatment, that is known as single blind. Double blind, when the patient as well as the assessing investigator are not knowing what type of therapy or what type of intervention is being assigned to these type of patients. When both are investigator as well as the patient are blinded, it is known as a double blind. When triple blind is when the patient, physician, assessing physician or investigator as well as the another committee whose monitoring is also blinded. Commonest is the DCMB. DCMB is the Data Safety and Monitoring Board, or a statistician who's taking out the results from that. And he is blinded to the assigned intervention or assigned treatment. He is always blinded towards therapy. So why should it be done? Because when a patient who knows that he is receiving a new or experimental intervention, most of the time he or she reports more side effects. Sometimes opposite also occurs. They reports less side effects. And then patient who is not on new or experimental therapy, he is assigned to a conventional therapy, then there is no in the therapy for the patient. So there are more chances of dropping out of that study by the patients. And then the patient may preconceived notion about the benefit of the therapy. Patient may think that the new therapy may be more beneficial, then they change their behavior. That is known as a Hawthorne effect. They change their behavior. For example, if you are using a new anti-diabetic drug, they become more they take diet more according to their dietary advice. They regularly exercise just to please themselves or their physician. This is known as the Hawthorne effect. And to overcome that, you have to use a placebo. What is placebo? In the pill form, you can have a same size, color, or shape or order, which is very similar to the drug which you are being tested. You are testing. And then there's sham procedures. For example, you are doing a research on a new surgery. Then you can do the anesthesia, give incision, but don't perform this surgery. It is a very difficult type, but this is how you create a placebo. What is placebo? Well, placebo is response to medical intervention which results from the intervention itself, and it is not from the specific mechanism or action of the intervention. It is not explained by the intervention. By just giving the intervention to the patient, it gives you a positive result. That is known as a placebo. This is a very interesting study which was performed in 1968. The two drugs with saproheptadine and trimeprazine was tested for the chronic itching. Chronic itching patient was randomized to these four arms. And the patient who were not getting anything, they were continue to have almost 50% of the itching score. Higher the itching score, the more the itching. And then the ciproheptadine was almost causing 50% reduction. Trimerazine also causing reduction. But the important to note, the placebo is patient who are receiving placebo are also having less itching score, meaning by they were having beneficial effect from the placebo also. So this is known as a placebo effect. The similar way that there is known as a nocebo effect, which is a negative of the placebo effect, meaning by when the patient taking medication experience adverse side effects unrelated to the specific pharmacological action of the drug. Most of the often the time, the person had a prior experience of these adverse effects. And this was very pronounced and came into the light when the Escort lipid lowering arm trial was finished and the trial results was published. And then these patients were followed up subsequently. And the patient who were getting the statin, they were told that they are getting statin. And then these patients who are getting the statin, and when the patients and physician came to know that they are getting statin, they reported more muscle-related adverse events compared to the adverse events reported in the trial phase. So this is known as the nocebo effect. So why should investigator be blinded? Because they may have an unconscious bias in assessing the outcome of the patient, and sometimes they do a compensatory treatment, meaning by the group which is not getting experimental therapy, they try to compensate by seeing them more and then assessing them more, they're taking more care of those patients. That is known as the compensatory treatments. So I will just give you one example about what is the importance of the placebo in this trial. This is the important trial which was published in the Lancet, that is a Simplicity Hypertension 2 trial, where the patient of resistant hypertension was treated with the catheter-based renal denervation therapy. So it was not a randomized trial. Sorry, it was a randomized trial, but it was not a sham control or not having any placebo arm. So it was a randomized trial. What it had shown, marked reduction in the systolic and diastolic blood pressure compared to the control arm. Control arm was not getting any therapy, whereas the renal denervation therapy was applied in this So these results were not found in the Simplicity 3, where the sham procedure was used. Sham procedure, what it was done, the femoral artery was punctured, sheath was inserted, the catheter was inserted into the renal artery. In one group, the renal denervation therapy was given by radiofrequency ablation. Another, it was not given, and it was randomized. So there, the Simplicity 3 The trial was negative. There was no difference in the systolic or diastolic blood pressure after this therapy. So now coming out to briefly about the study design. Study design, generally what we see the parallel group design where we assign treatment A, B, or C, and then the control arm, or then that sometimes we have a dose ranging design where we assign a low dose, a medium dose, or whatever dose in different dose and see the outcome. And then there is some crossover and the factorial design. I will just explain a little detail about these designs. In the parallel group design, what we do is that we randomize the patient, and when we try to see whether patient is having any outcome or not in the experimental treatment group or control treatment group. That is the simple parallel group design. The example of this is that one example is the Odyssey outcome trial where the PCSK9 inhibitor was tested. The patient were having that they were receiving the maximum dose of statin, and they were randomized to 1:1 fashion to the PCSK9 inhibitor twice weekly injection, subcutaneous injection compared to the placebo injection, and that it has shown there was absolute reduction of the 1.6% in the PCSK9 inhibitors. So this is a type of simple parallel group trial. And then in the Odyssey Kids study, it was a dose finding study. It was where a patient was, these kids were randomized to different doses of PCSK9 inhibitor, 30, 40, 75, and 140, 50 milligram, and that the effect of this drug on the LDL cholesterol was assessed. So this is a dose finding study. So another interesting trial design is the crossover design. What we do, we assign to the experimental group and control group, and then try to make observation about the outcome, and then it has a washout period about the depending on the type of therapy or the type of drug which we are using, and the other group will act as a control, and the experimental group will act as a control, and the control group will act as an experimental therapy. So this is a crossover design. So benefit of the crossover design, because when we are using crossover design, within the subject variability is not seen, and we have a reduced sample size. The number of the patient required are less, and it is very inappropriate for the acute illness. For example, with this one treatment, the treatment is cured, so then there is no way the other therapy can show any benefit. And then dropouts rates are also very high, because when patient gets some benefit or not benefit, then there's a washout period when they are not getting anything. So there is a very, very high chances of dropouts. It is important for the chronic illnesses where that, for example, the chronic pain, where it returns to baseline after the stoppage of therapy. So I will just show one cardiology example when cardiac resynchronizing therapy is basically optimized using two ways, by the hemodynamic way or echo way. So it was randomized in 1:1 manner by the hemodynamic way as well as the echocardiographic way, and the observation made after the 6 months, and then the switchover was made, and the group who was optimized by the hemodynamic manner then optimized to the echocardiographic manner, and the echocardiographic manner was optimized to hemodynamic. Again, after the 6 months of this change, the observation were made. So this is the crossover design. And then comes to the factorial design. Factorial design is when you are using a two or more intervention in a single experiment. Then the concept of the interaction comes. So when we think that the treatment A and B are having some interaction or no interaction, so there it can be applied. So advantage is that it can be performed, two experiments can be performed in less number of patients, less time of the patient. Complexity, but then there is a chances of the adverse effect because of the polypharmacy, because we are using two experimental drugs in this factorial design. So this is a very famous trial, HOPE-3 trial, where two antihypertensive and lipid lowering drugs were tested, and almost more than 12,000 patients were tested. And antihypertensive candesartan plus hydrochlorothiazide were tested against the placebo, and the rosuvastatin was tested against the placebo. So half of the patient were randomized to the rosuvastatin as well as the placebo, and half of the patient were randomized to antihypertensive versus placebo. But if you see that it's in the 2 by 2 factorial design, 1/4 of the patient were receiving both antihypertensive as well as the lipid lowering drug. 1/4 was receiving only rosuvastatin, meaning a lipid lowering drug, and 1/4 was receiving only antihypertensive drug, and 1/4 was receiving only placebo, double placebo for rosuvastatin as well the placebo for antihypertensive medications. I was also part of this study, and then you can analyze the data of these two arms. It was analyzed and it was seen that the cholesterol lowering drug rosuvastatin has shown marked reduction in the LDL cholesterol, ApoB, as well as the HSCRP level, and it has shown that there was a definite reduction, almost 25% reduction in the major cardiovascular events rates by the rosuvastatin. Whereas in the BP lowering arm, there was a definite reduction of the moderate reduction of the blood pressure in the patient who are receiving blood pressure. We see that the number is almost half of the total trial, more than 12,700. Half of them were getting analyzed as the candesartan plus hydrochlorothiazide arm, and half were analyzed as the placebo arm. So the patient who were receiving the antihypertensive had a moderate reduction, and this trial has shown no benefit of reducing the blood pressure in these moderate risk of patients. So with the same one study, we can take out two inference from the about the benefit of the antihypertensive drug as well as the lipid lowering drug in these moderate risk patient who are the drug were used for the primary prevention. So other types of clinical trials are the non-randomized trial. Obviously, in the non-randomized trial, you had to interpret results with the caution, and then the trials who are taking the external or historical control, you have to interpret their results with the cautions, and the uncontrolled trial, obviously, you have to interpret results with the cautions. Then other issues which you should be watching in any journal or any study is loss to follow-up. There could be a differential attrition rate, and there could be a poor adherence to the therapy. So a compliance of the patient, if the patient is compliant only for the 60% of the patient are taking therapy, then it's a very poor compliance. So the results are not will be taken with a pinch of salt. And then you have to come across this term which is known as the intention to treat. When the analyzing outcome, participants are included in analysis based on the treatment group assignment, meaning by if you randomize the patient to X, then that patient will be counted whether that X patient has taken therapy or not, regardless of treatment received or adherence. If you analyze the data according to the drug or device received, and then that it is known as the treatment received analysis as treatment receives. So you have to, this is the better way. It is to analyze the therapy in the intention to treat, but drug and device company loves to in this way, that is the treatment received as a treatment receives. So I will just go through the slides according to the drug development designs. Just run through these slides because research and development, it's a $1 million business, and you know that one new chemical entity and one biological entity takes almost 5,000 to 7,000 crore rupees. And then it starts from the concept and the idea, then preclinical, where the animal studies are performed for looking for the laboratory about the pharmacology, about the PK/PD and the toxicology, whether it is acute, subacute, chronic, or special side effects. And then it is that it is a new instinct. Then it goes in from the phases of study. Phase 1 is the safety and toxicity, and phase 2 is the safety and toxicity and dosage. Phase 3 is the safety and efficacy, and after that, this entity comes as a new drug application (NDA), and it is applied for the approval from the National Drug Approval Authority. And after that, when it comes to market, the phase 4 started, that is the post-marketing. So phase 0 is the first in man study where you give a microdosing, just exploratory, and then you, whether it is safe or not. And in phase 1, you have the healthy adult male volunteer are there, the drug is administered, and then you determine the absorption, etc. And then you also try to determine the maximally tolerated dose. Here the PK/PD studies are done. This is another phase 1, and after that, then you subject this study to a required disease or indication. It is a smaller study, relatively smaller study, and it has to be a double-blind placebo or active control trial. It has to be an active control or placebo control where you evaluate the safety or side effects profile. It usually lasts for 2 to 3 years, and after that, what we used to read in journal is the phase 3. Mostly studies which are published in journal, which is of clinical use, as a phase 3 study, where thousands of patients are enrolled, and it lasts for several years. And about basically is we verify the effectiveness of the new entity or new drug in a large group of patients, and we also monitor the safety profile, and then we also analyze the drug interaction, drug disease interaction, and then the long-term toxicology studies are also planned. And after that, the drug is sent for the approval by the National Drug Authority. And after the authority, it comes into the market. Then sometimes the phase 4 studies are planned. Basically, these are the pharmacoeconomic studies and evaluation in the different age, different types of patients. What is the sometimes we come across the overdoses, how it is being managed, and then sometimes it is unknown adverse side effects that has to be, when detected, that has to be explained. So these are the phase 4 studies. And after that, when that comes into the market, the post-marketing surveillance are also done by the industry. So how is drug performing in patients? Some new side effects are coming up or not? There, the post-marketing surveillance is done. So I think I have not taken much time. So I will just conclude by summarizing that all the observation studies could be affected by adversely by bias and variability. So you have to interpret the results of clinical trials by reading their methodology very carefully, and especially the attrition rate, loss to follow-up, and what are the crossover to the other arm. And the double-blind randomized controlled trial remains the gold standard in the clinical research. And then you had to interpret the results with the caution of the non-randomized trials with the historical control or uncontrolled clinical trials. Be aware of the phases of studies and post-marketing surveillance, because how phase 2 or phase 3 study, you must remember how they are being planned and how they perform. And then you have to read the results in context of intention to treat therapy and analysis, or as per protocol, as treatment disease protocol. So you have to interpret results of each and every trial by using these analysis. Thank you very much. And now I'm open for any questions. Hello.
No.
Yeah, is there anyone? Any questions?
Thank you, Sudeep. If there aren't any questions, we will move to the last talk for this 2 weeks foundation course, which is again a glimpse and an introduction to evidence-based medicine by Professor Abel Lawrence from Department of Immunology. Over to you, Abel. Abel, we have exactly 25 minutes. I'm sorry I gave you 30, but we have 25 because they have to take an assessment also for 10 minutes. So you'll have to wrap up in 25 minutes.
Thank you, madam. I think I have overshoot. So many
No,
minutes.
that's all right. Your topic was very vast, Sudeep. Even Abel's
Uh,
topic is vast, but I would like to ask him, request him to wrap up in 25 minutes.
Yes,
yeah.
I am not. I would like to have this more like a discussion and
Oh,
not.
Abel, we won't be able to have because they just can't, they don't answer back. You see, you try, but I don't know how successful you will be. You can give it a try.
I think those who don't answer should not get attendance because they can just
Well,
switch the
next time तेरे को बनाऊंगी मैं.
Zoom on, and then then not listen to anything.
Abel, next time तेरे को task master बनाऊंगी attendance लेने के लिए.
Whether they ask at least one question should be the criteria.
अच्छा ठीक है, चल शुरू कर.
Okay. First of all, we internal medicine, forget internal medicine, modern medicine, people claim that our system of medicine is so supposedly superior to traditional medicine. So what is the difference? What makes our modern medicine as medical science? Can anyone answer this?
Good morning, sir. It is because of evidence base.
Well, then brings us back to what is evidence based. See, it's basically it becomes see, most of you have to realize that most of what we do today in medicine are not actually science. Lot of things we do are cultural. You do it because your teacher did it. This is the way you have been doing. Somebody else has done it. There is a lot of culture in medicine. So the thing, it is unavoidable. There is no, everything cannot be covered by medicine, and a lot of this are part of training and tradition and recognizing this. And so medicine is a process, science is a process. Basically, something becomes a science only when you apply scientific principles to it. So just because, you have a recent scenario, recent situation where Ayurveda practitioners claim that they can also do surgery because they also study the same basic subjects. So essentially, just by studying scientific facts, does it make your thing a science? So essentially, the foundation of science, what is the foundation of science? Science progresses through refutation. Science does not prove anything. Science disproves things. Science has a process for telling something is more right than something else. So it doesn't actually say it's right, something is less wrong. So when you do various statistical tests or proofs, proof is a problem. Proof exists only in mathematics, whereas in every other branch of science, there is disproof. When you compare something quantitatively, you say that X is better than the other, one is less wrong than the other. So essentially, science can happen only if you can test something. So you have to be falsifiable at something. So the key test of something being science is it falsifiable. So if you make statements which cannot be tested, it won't become science. So what you need to do to apply science is turn everything into questions that can be tested and to test those hypotheses. And this can happen even on in everyday practice. Even on a single instance, you can do some tests. You can make a prediction. Suppose, how do you make something? You assume something is true and something is wrong, then make a prediction and make an observation. Suppose, how do you test? If I say that now it is night, is it testable? I'm saying this is not day, it is night time. How do you test that? Go out and look, right? So it's a single statement which is falsifiable. Whereas if I make some statement which cannot be tested, that can't count as science. So now coming back to oh, no, not this. So which of this actually is evidence-based medicine? Can you answer which of this is evidence-based medicine and which is not evidence-based medicine? Can someone answer? Hello? Hello?
Sir, listening to patient preferences and values, not evidence based.
That's not
Not
evidence.
evidence
Anybody
based.
else suggest something else which is not evidence-based medicine? Can you claim something specifically is evidence-based medicine here?
Cochrane reviews and meta-analysis, clinical trials.
Actually, all of these are part of evidence-based. Evidence-based medicine is not supporting trials or applying systematic reviews or meta-analysis. It is synthesis of evidence and applying it at the bedside. So the mistake in the statement is that you are putting meta-analysis and clinical trials at the center of evidence-based medicine. Patient is at the center of evidence-based medicine. You understood? So patient values and preferences are valid. So you need to apply evidence as applied to patient's values. So in a given patient, suppose if you want to, suppose you have a patient with cancer and you are making a choice on a decision. But one patient says, I have 3 months to live. I want to attend my daughter's wedding. I would like to, be good enough for that. I want to be participate and enjoy, and then I don't mind increasing lifespan. Whereas another person says, I have to live till another 2 years. So your choice of treatment can vary. And then you need to find the evidence that is suitable for the patient's goals. Don't you agree? One emphasizes quality of life, the other emphasizes quantity of life. Which is better, quantity versus quality? Who decides? Hello? Any response?
Patient.
Patient should decide. Similarly, there is a clinical trial and guideline says that suppose in rheumatology, one saying a patient fails on meta-analysis, so methotrexate, all drugs are failed, and the next line says you have to use this particular drug which is expensive, which is not available or is unaffordable. Then claiming that that particular thing has to be used because the guideline says so, is that evidence-based medicine? Evidence has to be applied to the specific circumstance of the patient. It could be about cost, and ultimately evidence should not be seen in isolation. So the process of evidence-based medicine starts with defining the problem at bedside, then looking at the scientific evidence, and then applying that evidence to patients. So this is the father of evidence-based medicine, as we know, is David Sackett, who started his career in McMaster University. Subsequently, he went to Oxford and set up the Center for Evidence-Based Medicine. He has defined evidence-based medicine as integration of best research evidence with clinical experience and patient values. So experience is necessary, and so there is role for physician experience, but the key thing is at every stage in your thinking you need to apply scientific principles. Your decisions and your choices should be testable. You should be able to, so when you look at a clinical sign, that is also a test. So you formulate a differential diagnosis, and then you decide that if you make a prediction, if I do this clinical bedside test, if the diagnosis is this, you will find this. If the diagnosis is not that, you will not find that. So essentially, even in such a scenario, you can even apply quantitative methods like Bayes' theorem to apply to turn a prior probability into a posterior probability based on even bedside tests or lab investigations. All of these are science. So application of science in bedside medicine starts from seeing the patient to making decisions on the patient. So evidence could apply to, this is where observational studies come into play, and in certain clear-cut scenarios, even personal experiences may matter. But the question is, there is a hierarchy of evidence and there is an applicability of the evidence. So coming to hierarchy, you are all familiar with this, pyramid. At the bottom, expert opinions, anecdotal experiences all are there. Then as you go higher up the ladder, you have cross-sectional studies, and then randomized control trials and meta-analysis of randomized control trials are, considered the gold standard of trials. But all of them matter depending on the situation you have, whether the evidence is available or not, and more importantly, the applicability of it. The reason observational studies and case series are not considered high quality is that they are more context dependent. That is, everything else that went into the thought process and analytical process at that point in time, mostly things which are not mentioned in papers, are more relevant than what is mentioned there. Whereas clinical trials and systematic reviews, especially prospective studies, have predefined context. So they are more easier to understand. Understood? And then highest level of evidence is, our guidelines are considered highest level mainly because guidelines are use methods of evidence-based medicine and put these findings of control trials and systematic reviews in context. But even these guidelines may have pitfalls because the circumstances may vary from country to country. Some country may have insurance and other legal requirements which limit what can be done. So many a time, when you see a guideline, you can easily see the background, the political, economic context of that country. So all of these have to be factored, and you need to adapt the evidence to your particular context, your legal, economic situation, and the patient at hand. So let me give an example, counter example of evidence-based medicine, because evidence-based medicine is highly criticized. But so some of this particular case, this paper was published in BMJ. So these examples are good at identifying the limitations of evidence-based. So parachute used to prevent death and major trauma related to gravitational challenge. So this group, they did a systematic. What would be the outcome? Can anybody guess? Hello. Anyone has a comment on this study? What is the fallacy here?
Actually, it is a known fact, and they're doing a analysis on that. Parachute has to be used in.
How do you know it's a known fact? See, highest level of evidence is a systematic review. They have found no evidence that parachute is beneficial. So the thing is, not everything can be subjected to clinical trials. You understand? So what are the requirements for trials? The trials require equipoise. Suppose there is a patient whom the physician or the treating team thinks that needs a particular treatment, they won't be enrolled in those clinical trials. So only those patients who can go through consent process, which itself takes time, and where there is a possibility of doubt, has clinical trial, and many of the obvious things do not get tested. Everybody believes that a particular treatment has compelling indication, then nobody will test it. People actually will use it. Do you remember anything recently? In the beginning of the COVID pandemic, everybody was using hydroxychloroquine. Nobody was even willing to allow a randomized controlled trial of the same. But some people went ahead and did it and proved it doesn't work. So when you read evidence systematic reviews, you need to look at the social context, and these can vary from time to time, and then understand the limitations of trials and understand the limitations of what can be tested in trials and see if that is applicable. So in this, they did not find any randomized controlled trials and recommended that people should volunteer for a crossover trial. And then subsequently, another group of researchers actually went ahead and did a, this is also a mock. Actually, this was basically making fun of the whole situation. They did a randomized control trial and showed that parachute did not work. So what was the problem in this study? See, on paper, everything is fine. They had 192 patients screened and 120, 92 patients screened, and finally 23 of their friends were randomized. And the problem was that when they, according to their protocol, nobody on aeroplanes were willing to jump with and without parachute. So what happens is, when you design a trial, you need trials where one, you are confident ethically to do something, and then the patient should be willing to volunteer for it. So and then they had to modify the protocol, and finally they recruited people who jumped from stationary aircraft. Okay. So obviously there was no difference in the outcome, and they concluded that jumping from parachute has this is actually what happened. So you cannot judge the quality of a study or the context of the study by looking at the abstract. So this is the point of this paper. Most people, what do they look at? They study a paper, they look at the heading, the title, and then look at the abstract results, and you're happy with it. So what is the most important thing that you should look when you look at paper? It is the methods. How many of you read methods when you look at a paper? Hello? So when you look at a paper, so the introduction of the paper tells you what is the logic, why they did a trial, and the methods tell you what they did, and all the details on quality and relevance, everything comes from the methods, which is a section most people skip through. Sometimes important details are left out, are in fine prints of the method. So here in this paper, it is said that the aircraft were traveling at 0 miles per hour. Understood? They were stationary aircraft. So this is the detail. So and the thing is, around 10 years ago, we had a patient with massive pulmonary thromboembolism. Her blood pressure was maintained. She was breathless, but echocardiography did not show any right heart failure. So should we thrombolize the patient? That was the question. At the time, the Cochrane review said that there was no survival benefit from thrombolysis in pulmonary thromboembolism patients. And then what was the key detail was that the randomized control trials included in the Cochrane review had patients with a duration of the time from the pulmonary event recruitment of 5 days minimum. So what is the issue here? If somebody has pulmonary thromboembolism and 5 days have elapsed, what is the likelihood of dying? Hello? Hello, has anyone answered? Most patients who are likely to die would have died. And naturally, if in the most of the trials, there were very few mortality even in the control arm. So in such a scenario, the trials which looked at mortality as an outcome had no statistical power to see any difference. So our patient who had a pulmonary thromboembolism developing in the ward, that is not relevant. The RCT was not relevant, and in the end, the patient was thrombolized and she got better. Her breathlessness diminished, improved. Within 2 hours, she was better. So the question is, more important thing is, when you look at the thing is, study the details of the trial and how the trial is applicable to your patient. So your patient is at the center. The trial is not at the center. So the application of evidence-based medicine has 5 A's: appraisal of the problem, identifying the problem. Identifying the problem happens at the bedside. You assess the patient. This is a particular, you have to define the problem and then redefine the problem as a hypothesis so that you can look for studies which address that problem. So the question is patient in whom it applies. So let's go, if you go back to the pulmonary thromboembolism patient, that is pulmonary, we were interested in pulmonary thromboembolism within less than 24 hours. Whereas most trials had patients who had more than 5 days. Of course, as an update, the latest reviews shows that even all patients, there is evidence of survival benefit. As more trials have accumulated, things have changed. Then the intervention, what treatment you are going to give. So these should include the route, the dosage, when, how long, all these have to be defined. And the comparator, whether there is a placebo controlled study or an active comparator. One of the problem with active comparator is that if the active comparator itself is not effective, then a non-inferiority design may falsely say identify a drug as useful. So the selection of comparator and outcomes such as death, etc., are hard outcomes, whereas quality of life, you can have surrogate endpoints as soft outcomes. Again, different outcomes may vary based on how much potential for bias there is. Patient reports outcomes and the physician report outcomes may be more prone to bias than laboratory measurements and such objective outcomes. Then acquiring those evidence from science literature, appraising or critically reviewing those evidence, and then applying that application of the evidence to bedside. And in this scenario, you need to see how relevant is that evidence to your patient and how to adapt that evidence to your situation. So even though we say that systematic review are highest level of evidence, it is possible that one of the trials at RCTs which are part of the trial may be more applicable to your particular patient. So that may have a higher weight in a given scenario. So you need to adapt the evidence available to your patient. And most important thing when you look at a trial is the quality of the trial, and the quality of the trial, Dr. Sudeep has done a good job outlining with the various steps of a clinical trial methods. And in the methods, most important thing is whether to know whether the trial is applicable to your patient is inclusion and exclusion criteria. It is possible that the RCT may you have very severe patients, whereas your case is mild, or maybe your case may be severe and the trial included milder patients, and it may have that whether your patient may be part of some specific narrow subgroups, whereas whether the study available population was broad or narrow, and there could be inclusion bias, there could be bias in the kind of patients that were included, which could sometimes vary from center to center. So all of these are potential issues in the case definition. Then how the interventions are defined, whether those interventions, the route of administration, that is relevant to your scenario. But the most important parameter that determines quality of a trial is actually randomization and concealment. What's the difference between concealment and randomization? Can somebody answer? Hello? Hello? Does anyone, you already had a class on clinical trials. What is concealment? How is concealment different from randomization? Hello, anyone has an answer? Has anybody, how many of you have heard of concealment? Concealment is hiding the randomization sequence. That is, a patient who is being enrolled should not know which group he or she is. Neither the patient nor the study team should know which group the next patient is going. And this is separate from randomization. You can, and sorry, so this is rather, there is no randomization without concealment. If there is no concealment, randomization sequence will be public, and the benefits of randomization won't happen. And this concealment is separate from blinding, and concealment is more important for open label studies. So you can have a randomized study which can be open label and valid if you have concealment. But if you don't have concealment, obviously blinding doesn't work. So this is necessary. So concealment, blinding, randomization, all these go together, and it has been proven that these actually affect the outcome study maximum. And so this is something we always should look how the method of randomization use, the method of concealment use, and methods of concealment include opaque envelopes, or you can use a very good placebo so that nobody can actually, and you can actually allocate the drugs by particular code numbers so that nobody knows whether it's placebo or, and in fact the use of interactive voice response system is actually a method to keep the concealment secure. So the randomization sequence is not at the study site, and it's revealed only after the patient is enrolled and the number is generated. So basically, IVRS is also one of the methods for maintaining concealment. And then in terms of outcome assessment, imbalances in follow-up. So some patients, that can actually affect results. Suppose if patients who are not doing well and they drop out of the study and their outcomes are not included, it can be a serious red flag. So when you are looking at the quality of a study, you should see whether one, the level of dropout is not too high. The dropout rates are high, that affects quality of the study. And then even if not, are they similar between the study? If one group has more dropouts, that means in such a group, it is possible that concealment and blinding may not be maintained properly. And so that can be a major, and second, whether the size of the study depends on whether the study has power. So the type 1 error is where you falsely identify something as significant, whereas actually there is no effect. Your null hypothesis is true, but you have falsely, identify something. But type 2 error is the opposite. That is, there is a significant, the true effect is there, but your study wasn't big enough to actually detect that thing. Both type of, so absence of type 2 basically looks at absence of evidence is not the evidence of its absence. So you need to see whether the trial had sufficient statistical power. So sometimes that may not be the case. So you have, suppose now you have identified large number of trials, and suppose there are multiple trials, and then the method where these multiple trials are results are combined is called systematic review and a meta-analysis. So the key thing about a systematic review and meta-analysis is that systematic review is the method in which you are collecting the data, and meta-analysis is a mathematical, it's a quantity method where you combine the results of several studies. So for systematic review to be evidence-based, you need to follow the regular method, just like a clinical trial, just like a scientific study. You need to first of all identify the problem, define the problem, ask the questions, and redefine it as a hypothesis. Again, like a clinical trial, you need to define the patients, the interventions, the comparator, and outcome. And then these protocols have to be reviewed, and a priori. So compared to the 5 A's, a meta systematic review has 6 A's. So a priori planning and declaration, that is, you finalize the protocol, and once the protocol is then you start. Hello, anybody has a question? Somebody is speaking.
Abel, we'll have to finish because they have assessment as well.
No, I won't take much. Then you have to systematic search, then appraisal of the evidence by quality, and then compile it to a meta-analysis, and then look at the applicability. So comprehensive search, basically you have to search various databases, and most of the time searches are not comprehensive. That's why you don't find evidence. So search strategy has to be tested and validated so that you don't miss any relevant studies. And then this forest plot is a method for combining the effects. So suppose you find that some studies are showing benefit, some are not showing benefit, and there is a difference. So you can combine it using a meta-analysis. In meta-analysis, you are weighting the outcomes, the effect sizes of different studies based on their precision. Precision means accuracy. Mathematically, it's inverse of variance. So, and there are various methods. As for shortage of time, I'm not going into it. And when you look at this forest plot, you need to look at the effect size. Suppose, for example, effect sizes like hazard ratio, odds ratio, etc. The key thing is they should not cross 1. Whereas difference between means and standardized effect sizes, the no effect margin is 0. So if a means crosses 0, it is not significant. If a hazard ratio, odds ratio, relative risk crosses 1, it is not significant. So, and then you have to look at whether looking at the forest plot also helps you to know whether there is heterogeneity between studies. So if there is heterogeneity, then you need to look at the sources of heterogeneity. That is, heterogeneity means different studies have, some are widely different with non-overlapping variances, and there are statistical tests also for heterogeneity. And then you should be looking at before you do a meta-analysis, you should look at the sources of bias, which will be in the randomization, means how the random sequences are generated, whether people really use their randomization. People can claim they have used randomization when they haven't actually used anything. Allocation concealment is the next important. Then blinding. When you look at blinding, double blind should not be used. Double blind, you can blind, as Sudeep said, at multiple level. You can blind the patient, blind the investigator, blind the pharmacist, blind the nurse, blind the assessor, even blind the statistician. So when you report, you have to see whether all of these have been checked, who has been blinded and who is not blinded. Then other source of bias. Another source of this is publication bias. So if the study is small or negative, it's very difficult to get published. No journal wants negative study on their public, because nobody reads them. So the one method to look at publication bias is the funnel plot. What you see in the funnel plot is that smaller studies of negative, they are missing. So you can see if the plot is symmetrical, there is no publication bias, and asymmetry in the plot means there is publication bias. And there is another kind of bias which can arise in statistics. Many people have the habit of hunting for a suitable statistics, and then you publish based on that. So that is also called publication bias in situ. And this is why protocols have to be published in advance. You need to declare what statistical analysis you are going to do, and then do that. If you shop around for statistics, that will bring in a systematic bias into studies. And another suppose when you have heterogeneity, by doing meta regression, that is basically you find a independent variable that can affect the outcome, which is called a moderator variable, and see how the effect size varies with it. So on the left side, you find that the moderator variable predicts the outcome, and in such a scenario, that's an informative thing. Sometimes you find that moderator variables are not predicted, but there are different clusters of studies, in which case your job is to find the subgroup. So there may be differences between groups of studies which have different outcomes. And so subgroup analysis may identify groups of patients where there is trials where there is an effect in another group, and then you have to look at the methods and find out what is the difference. So it is possible that one of these groups may be more applicable to you, and we can differentiate whether the particular treatment is useful to your patient or not. And the key concept when you apply the results of the studies to your bedside is exchangeability. Exchangeability is, can you exchange your patient with the patients in the studies, in the system, in the clinical trials, or meta-analysis. It is possible that your patient may have some comorbidities or complications, or patients are too severe so that they will be excluded from the clinical trials. So when your patient does not match the kind of study population, you need to review this evidence with a lot of salt and apply your clinical judgment. Again, there is a place for clinical judgment, experience, and your overall scientific knowledge. So this basically you are extrapolating. When your patient doesn't match the study population, you are extrapolating the studies. And when you extrapolate, there may be mistakes, and you have to keep your eyes and ears open, and then apply these things. So that's a very important part of. So don't blind. If this particular trial says this, so you apply it. No. So general
more time.
Last two slides. And this is an important concept. It's very important.
Please, you really need to wind up now.
It's called survivorship bias. During the Second World War, the U.S. Air Force collected data on the damage to aircraft. Then they found that certain parts of the aircraft had more holes, bullet holes. So they decided to strengthen the aircraft at that position. Then they consulted a statistician. What the statistician did, I forgot his name. He said that no, don't strengthen them. You look at the areas where there were no, bullet holes and strengthen those areas.
Abel, sorry, how much more time? I'm really.
Second last slide. So the key point is that if you get hit in certain places, then the aircraft won't come back. So in fact, the places where bullet holes won't affect survival are more likely to come back to the airfield. So there is a bias towards survivors. This is so suppose let's take pulmonary embolism. Patients who don't survive, who suddenly die, they will die at home, and your studies of pulmonary thromboembolism reaching the emergency will not include them. So similarly, survivorship bias is an important thing which happens before any clinical trials. That is, again, by the time you can take consent, etc., the patients who may be saved may already be dead. So survivorship bias is something which happens even before you enroll any subject in observational studies or clinical trials. And this is where again, another thing is a concept of black swan. Most of the statistics assume normal distribution. They don't consider rare events or what is called thick tail events. Sometimes very rare events may have much outsized consequences. And if you don't factor those things, then you may have a bad surprise. Usually, that is it's called asymmetry of risk. Suppose even though clinical studies may be equivocal, error on one side may be more severe than the error on another side. So let's say this is a issue that happened with pandemic. In the beginning of the pandemic, it was not very clear whether this outbreak of this new virus in China would cause a pandemic or not. The thing is, there was no way to know. But the thing is that if it doesn't become a pandemic, just very little consequence. But once things go out of hand, the consequences are huge. So we need to factor in asymmetry of risk when you look at evidence. Sometimes even when there is no evidence, asymmetry of risk may tilt your hand in what you do. And considering uncertainty is also part of science. So there is a role for clinical judgment and quantity, and all these you can apply quantitative reasoning, and Bayesian approaches can help you apply to a bedside patient, and time doesn't allow me to get into any quantitative matter. So the message is that evidence-based medicine starts at the bedside, and application of scientific principles to tailor to make to apprise and apply the available scientific material to the situation at hand. And it is not merely quoting RCTs or meta-analysis.
Thank you, Abel.
Now we will be having the assessment. Again, this will be done in Google Forms. We will be sharing the link in the chat box. So you have to mark each option. You have to check each option because it is not a single option, single correct answer. Multiple answers can be correct. Okay, and there is a negative marking. Also, if there is any wrong option has been selected. So timing will be 30 minutes and there will be 90 marks. It is common for both medical and non-medical students. So we are starting at 120. So we will be closing the link at 150. Can everybody access the link?
वीडियो ऑन करना पड़ेगा, इसको वीडियो ऑन नहीं हुआ लास्ट टाइम भी हुआ था। चैट बॉक्स में डाल दें, वो यदि एक्सेस नहीं होने नहीं चैट बॉक्स में डाल दिया नहीं लिंक एक्सेस नहीं होगी तो चैट में बताएं।
The link to the assessment is in the chat box, just like the part 1. मैं आपको फिर से
क्या बोलूं? फिर से डालूं?
This time, after submitting the answers, you will be getting a confirmation that you have successfully submitted the responses. You don't have to write it again in the chat box to confirm whether we have received the mail or not.
If any one of you can't access, please write in the chat box that you can't access. If we don't get any responses from you about problems in accessing the link or accessing the Google Forms, we'll assume that all of you could access, and if you don't submit it, then you don't get the credit. So any issues should be brought up right now. उसमें से 6-7 तो हम ही लोग हैं।
50 यहाँ तो बहुत कम लोग कर रहे हैं।
नहीं 50 हो गया, देख पीएचडी स्टूडेंट से हट गए ना।
ओके हट।
हाँ लास्ट टाइम
68 थे मैम।
हाँ तो पीएचडी स्टूडेंट्स भी थे ना। आज के इसमें अपना इस वीक से हमारे क्लिनिकल स्टूडेंट्स।
ओ तो वो जो स्टूडेंट फोन किया था वो
पीएचडी। अच्छा